Good afternoon, everyone from the World Health Organization headquarters in Geneva. My name is Alexandra Kuzmanovic, and this is our weekly live Q&A Ask WHO about COVID-19. Today, our guests are Hanan Balkhy, who will be answering your questions about COVID-19 diagnostics and innovation that has been happening in this stream of work and response to COVID-19 pandemic, and also Edward Kelley, who will answer your questions about essential health services that have been heavily interrupted due to pandemic. Good afternoon, thank you for your time, and thank you for being open to answer the questions from our social media viewers. I would just remind them that if they're watching us on Twitter, they can ask their questions by using hashtag AskWHO. If you're watching us on Facebook, LinkedIn, or YouTube, please leave your comments, leave your questions via comment section. Hanan, Ed, how are you today?
Good, great.
Thank you again for your time to join us and answer the questions. There have been a lot of questions coming in on these subjects in previous weeks. But before we start, can we remind our viewers about the Accelerator, the initiative that WHO and partners have established to rapidly develop new tools to fight COVID-19 and also to provide equitable distribution to countries in need?
Of course, yeah, maybe I'll go first.
Yeah, go ahead.
I think this is a great initiative. I think, of course, as everybody knows, we're facing the pandemic of the century, if you will. And I think without having this solidarity and collaborative work among all types of organizations, private sector, pharma, research entities, we will not be able to tackle this. And I think that this initiative to bring all these agencies together to fight this pandemic was the essence of the Accelerator. And we see some really great progress over the past few months.
Thank you, Hanan. Can you please tell us more, what are the different type of tools that WHO and partners are working on within this initiative?
Yeah, I mean, it's a great question. I think the important thing to, also building on Hanan's point, is that we had a number of months of response on this, and that is all continuing. The Accelerator is really trying to look ahead to when we have at big scale some of these tools and what's specifically needed in countries. So for WHO, we've never stopped working, so it's not that we all of a sudden envisioned something new on this. It was really building on what we've been doing. So the tools areas are really around diagnostics. That's already something that's rolling out, and Hanan will speak about that. Around the therapeutics, there's not so many right now that have been shown to be effective, but a few, and countries need to figure out how to get those into regular clinical practice. And then obviously the big push will be around the vaccines, which doesn't exist yet, but we're hoping for in early next year, and the teams are working on that. Then all of those get rolled out in countries in health systems. So there's not two health systems, one that responds to COVID and the other that delivers babies and fixes broken arms. It's the same people. So the health systems connector is the fourth piece of the Accelerator that really works on what are the enablers that need to be put in place to really make sure that those things land in a good spot.
Thank you very much, both. Hanan, you're working on Diagnostics Pillar. What is the main objective of this pillar?
Again, thank you very much. Very good question. And the diagnostics is one of the very early tools that is used in any kind of emerging pathogen or any disease, really. You really need to have a diagnosis so that you know what you're dealing with. And the diagnostic pillar, again, builds on several entities that have already existed before. But to make it simple for the audience, it focuses on four main areas. The first one is that we need to improve our diagnostic tools, and that we can talk about that for hours as well. But we need to improve the types of diagnostics and making them more accurate, faster, quick turnaround time. The other part that the diagnostic tool is working, the pillar is working on, is the market readiness. How do we assist the countries in improving their regulatory procedures so that a country can approve a certain test, for that matter, other types of tools? And then is the supply. How do we make them available? How do we, because again, the sheer numbers of demand or what is needed to solve this pandemic or to respond to this pandemic, we need large quantities. So we need to look about supply and procurement. And the last one is, how do we prepare the countries and assist them to utilize these diagnostics in, as Ed said, within the healthcare systems that already exist. So how do we preparedness? And that's the fourth area of the diagnostic pillar.
Thank you so much, Hanan. And here is the first follow-up question coming from Stanley Menezes, watching us on Facebook. Which test is the reliable test which can detect COVID-19 at the earliest?
That's a good question. So we want it early, but we also want it to be super accurate. So the two tests that we would be, either one of them is either the PCR test, which detects even small amounts of the DNA of the virus, because it goes through a phase where it amplifies it. So it picks up a small quantity, goes to the laboratory system, goes through what is called replication. So it kind of, a cycle of enhancing the quantity to detect it. So that takes a bit longer, and you can detect it at an early stage of the disease. Then you have the antigen RDT test, which detects the outer part of the virus itself, of the shedded virus. It does not amplify what exists. So there's a more likelihood of missing the diagnosis, because if you have small quantity in the very early stages of the disease, you might miss the diagnosis. And that can be done, though the benefit of it is that you can do it at the, in the field, at the bedside. It's a rapid test, and those are what we refer to the antigen RDTs. So those are the two types of tests.
Thank you very much, Hanan. There is another question that is coming. What is the test accuracy, and who is overseeing the quality of those newly developed tests before they are put in market?
Yes, that's a great question. So the quality of the tests, or how accurate are they, depends on the ability for it to specifically detect the DNA of the virus itself. So the PCR testing, the ones that require sophisticated laboratory services, those are the more accurate. We refer to them in science as that they're very sensitive. They'll pick up the actual disease, and they're specific. They will pick up the specific disease. So it will be, if it says it's COVID, it's COVID. If it says it's there, then it's there. So those are the sensitivity, specificity. The quality of it, of course, as for any diagnostic or therapeutic, it has to go through studies, research protocols, that they test them on a population or on people who we can have a gold standard. So the gold standard is the PCR. And again, the WHO at a very early stage of this pandemic was able to announce and to show the sequencing of the virus, and that's why we can see this rapid evolution of the PCR. It came out very, very early, I think sometime mid-February or so. And when the sequence of the virus was announced, the ability to develop these diagnostic tests became much easier, and that's why we see them here. But where can it go wrong? Again, you have a very critical step at the beginning, which is the swab itself. The nasopharyngeal swab, everybody refers to it as the brain, the brain swab, which it's not. It goes into the back of the nose to the upper part of the throat. And the person needs to know how to perform that specific test. And if that step is not done accurately, then we can have a problem. So we're hoping that we will have more innovative tests coming down the pipeline that will depend on saliva or on a throat swab and so on.
Thank you very much, Hanan. Ed, you've been working on a health system pillar. Can you tell us more about that part of the work? And also, just to make the connection, when we have those new tests coming up and new tools, how do we train the health workers around the world who are working on the response to use these new tools in a proper way?
Yeah, actually that's one of the big bottlenecks that occurs almost, if you look at any big problem that has faced WHO or the world in terms of outbreaks or new diseases, the aspect of bringing the health workforce up to where it needs to be has been one of the biggest challenges. And actually, this is one of WHO's big agendas in quote-unquote peacetime, is strengthening the health workforce. We've talked about a 400 million shortfall in terms of health workers around the world that we need to expand on, but that kind of training is part of what the diagnostic team, the pillar that's leading on that, is supposed to help strengthen. But then also in the health systems work that WHO and partners are doing, along with the World Bank, Global Fund, UNICEF, and other partners working on that. There's a piece of work that looks at how to strengthen clinical care delivery, so the testing and also the care delivery that comes afterwards, and how to keep health workers safe as they take those tests, and then as they need to treat those patients that test positive afterwards.
Thank you very much, Ed. There are a few follow-up questions coming up already. What would be, again from Facebook viewer, Mitchell Collier, what would be the most critical factors for evaluating and selecting a PCR test technology?
What would be the factors to select one?
Yes, for evaluating and selecting a PCR test technology.
Well, actually, maybe I didn't really fully respond to the previous question, is how do we regulate these and how do we approve them? So that maybe it's pointing to that question as well. So when I mentioned that when a test is developed based on the sequencing of the virus, whether you're going to make it a PCR test or you're going to do an antigen RDT test, those tests eventually need to be studied in the field, right? And then you have the regulatory body within the WHO, so we have something called the emergency use listing, where the companies that are developing these products show an interest in listing their product on the WHO website. And to do that, it has to go through an assessment, so looking at the sensitivity of the test, the specificity, and comparing it to the gold standard now, which is the PCR testing. And I think we were very lucky to have the sequence of the virus available and the PCR as a gold standard to compare. So the question is, can we use this test? Is it going to pick up the disease? Will it pick it up early on without the person having symptoms? Will it pick it up only in the very first days of signs and symptoms? So all of those entities need to be evaluated. So the guidance on a specific test, it will be regulated, and we have to give clear instructions on when to use it. When will it be of value? Because not every test will be of value for all of the scenarios that are out there. And there's a lot of scenarios, right? So that's what actually happens. And so for out of, if I could say, 50 of the antigen RDTs that are in the pipeline, only 2 have completed the very strict, stringent evaluation, and they are on the emergency use listing on the WHO website.
And I think, just to add to this, sorry, Alex, is like this question of the interaction between new technologies, new innovations, and then capacity at global and country level for regulating them. If you go back to H1N1, actually this was probably one of the biggest bottlenecks that WHO had, but that all countries had when we came with the vaccine, was actually national regulatory capacity to get the vaccine going. So this is where the kind of, again, the peacetime regular work that WHO and other partners do is laying the foundation for this type of emergency response. So it's something that needs still to be reemphasized and strengthened.
And to add to that as well is the turnaround time for what the WHO has put effort and energy in. The turnaround time for evaluating these new products has been extremely fast. And trying to support these new companies these entities in submitting their products for evaluation is taking a much shorter time than it did in the past. So that's also very good, important news.
Thank you very much. Here's a follow-up question coming from a LinkedIn viewer. Looks like the PCR test is more superior, right? So can we just explain when do we use a PCR test and when do we use antigen tests? So
the reason why the PCR is more accurate, it's because it's based on, as we said, testing the DNA or the RNA, amplifying the genetic material of the virus itself. So it is superior where it has a higher sensitivity and higher specificity, so it's much more accurate. But it has the backfall of the PCR testing is that you need a laboratory to be able to perform that test. And once you have a laboratory, then the capacity and the skills to run such equipment may not be available in all of the countries. So that's where you have the pros and the cons of the PCR testing. The antigen RDT, on the other hand, is much quicker. It is not significantly inferior, the ones that have been in the EUL testing. Again, I don't want to get too technical, but there are certain cutoff points of how much can it detect. And that's why we have also established for the national and subnational level guidance on scenarios. When can we use the antigen detection test? Because as we know that many of the countries do not have the laboratory capacity for the PCR testing, yet we need to have information about the disease in those countries to guide on tracing and testing and isolation processes. So again, there's pros and cons for each one of them. Both of them are, so again, a common question, by the way, is the antigen test going to replace PCR? It's not going to replace it. So there are scenarios for each one of them.
Thank you very much, Hanan. Ed, we mentioned at the beginning of the conversation that pandemic has caused a lot of interruption in essential health services. So what's the latest status? What's the latest data we know that people are lacking essential health services?
Well, this is something that WHO has built in as one of the pillars of its work now. With this particular outbreak is looking specifically at the continuity of essential services. And, you know, for those of us who work in other areas, this is incredibly key. If you looked at the height of the early phase of the outbreak back in the late spring, early summer, you had, at least what was reported to countries in our survey that went out to about 105 countries, you saw that about half of all health services, across, at least what countries were reporting, were interrupted or disrupted severely or partially disrupted. And these were some of them services such as dental services or rehab services where, you know, if you have to wait a bit of time, perhaps that's possible to pause those services. But other ones that were also very interrupted were important emergency room services, life-saving blood transfusion services. So these are things that should really never be interrupted. So now that we are seeing cases rise again, I think one of the things we're realizing is how sort of the delivery of medicine has changed a bit. And it's quite clear that our concept of what is essential, and probably this is like a life lesson for us and not just a lesson about essential health services, but I think it has to expand. You cannot go 2 years where people don't see a dentist, where they don't get rehab, where they don't have their mental health and substance abuse counseling. So we're working right now on revisiting the guidance, looking at how can countries safely restart paused services. And the bottom line is that all countries and communities will have to figure out ways to access a bit of an expanded set of essential services and do so safely. So if you look at some of the key services that we're looking at now, like routine and immunization and outreach services, in some cases 70% of those were interrupted. Many countries have figured out ways to restart those now and to do those safely. So we're going to be repeating that, and I think it would be great to come back and talk about the results in about a month's time.
That would be great, thank you. What is the advice for people who need other health services, how to go to the hospital and to stay safe during COVID? Because we've also seen some comments from people that they are also scared to go to a health facility during this time, but they also need to go and see their doctor. So what would be our advice and what is the safe way to do it?
Yeah, I mean, we can both comment on this, but I think the bottom line is that WHO, all countries have these days guidance for care seeking and also for where to report in terms of if you are a suspect case and how to handle getting care and a diagnosis like we've been talking about for COVID. So that's one sort of track of services. But all countries also have figured out ways to surge their health services and be able to manage and both assess and triage patients when they come into the health system. And I think we have to realize, too, that patients access the health system in many different ways. So related to community care services, related to emergency care services, but then primary care is going to be very, very important. And the fact that patients are dealing now, and particularly in the Northern Hemisphere, with the flu season coming and being able to access those services safely is one of the aspects that all countries will have to be rolling out in the coming months.
Thank you so much, Ed. There is one follow-up question about blood donation. How much has blood donation been affected due to COVID?
Most of what we have seen, we don't have, WHO doesn't have hard numbers on blood donation. In terms of blood services, I already mentioned that in some cases 20% of blood transfusion services were interrupted. But most of the anecdotal information we've gotten has said that a lot of blood donation drives have been restructured, curtailed briefly, but most of our regional offices have restarted the push on blood donation. For people who don't know it, June 14th is World Blood Donor Day, so this year was unlike any other day. We didn't do it in person, but we did push countries to figure out ways to safely donate blood, and I would just encourage all of the people listening that blood donation can be done safely, like almost all health procedures these days. So there's blood donation drives in France, Switzerland, right around WHO right now, and I'm sure there are locally, so people should be looking out for that.
Thank you so much, Ed. One more question we received is how much attributed life lost is expected globally due to COVID, but from other health diseases?
Yeah, this is a big question that people have asked. WHO has a modeling group that's been working with academic partners and government partners looking at modeling the potential impact of both COVID and non-COVID lives lost. WHO hasn't itself come out with an official figure on this. Some estimates are that, from what we've looked at, is that the potential interruption of services will have a much bigger impact, potentially, than the impact that COVID has in terms of overall morbidity and mortality, but we haven't come out with a figure ourselves recently.
Thank you very much, Ed. Hanan, we are getting more follow-up questions on tests. The first one is coming from Angel Torciello. How long does it take for the test to be able to detect the virus?
You mean when does the result of the test become available to the patient?
I think it's how long do we need to have a virus in our body so that the test can identify.
Can be positive, yeah. So what stage of the disease is the test positive? So those are two very different questions, because, and it's very important that we understand what the audience is, because both of them are actually, we get both of these questions. So the RT-PCR testing can be positive a few days before the initial symptoms, so within 1 or 2 days, 24 to 48 hours, and then most likely within the first 5 days of illness. Again, patients who would have their symptoms. And the antigen RDT at the beginning of the test, of the beginning of the illness, it may not be always positive, again, because we're talking about you need large burden of the virus, we call quantities of the virus, because you're detecting what exists in the secretions of the respiratory tract, right? So I think that you can have it at definitely when a person is sick in the first days of illness, both would be positive. And for RT-PCR also within, a day or 24 to 48 hours before. But again, a lot of this solid research has not, we need more studies in this area to definitely understand better. Especially with the new tests coming in. When we start having the sputum swabs and the nasal swabs, it would be really interesting to know. And all of that information is still not clear yet.
Thank you. Here's another question. Is there possibility of false positive on antigen tests?
That is one of the other issues, because when your specificity, it's not specific to that virus, it doesn't reach 100%, it reaches 99%, if you will. And people might say, okay, but that is still very, very high. Yet it does allow for some false positive testing.
Thank you. You mentioned that there are a lot of tests in the pipeline and within the diagnostic pillar on the Act. Are there any self-administrated tests in the pipeline?
Well, even with the PCR testing, by the way, the nasopharyngeal, we've seen people been way more creative, I think, during this pandemic than they have in the past. Because I've been doing this for quite a while, and I've never thought that you would want a nasopharyngeal swab to be self-administered. But I think in some countries we've seen them asking people to administer their own nasopharyngeal swab. The problem with that is that if they don't do it accurately, if they don't go far enough in the back and they don't turn the swab enough times to collect the sample appropriately, you might have a false negative, not because the test is bad, but because the method of collecting the sample was not very good. So the self-administered tests would be really good once you have a nasal swab, you're just at the tip of the nose, or a throat swab for those who can tolerate a little bit of a gag reflex, or sputum, which would be the optimum. But that's what we're hoping for in order for us to start using this more, giving it an example like a home pregnancy test, if you will. So at least people have an indication they're not feeling too well. If they have a positive test, they can self-administer it at home, depending on how ill they are and what's the situation of the epidemic in that specific community, whether there is a chance to confirm it at a healthcare facility or a clinic with a PCR, whether it's needed, then that will be the next step. And I think that process is when I spoke earlier about the guidance of usage, which depends on the country, the community, the resources, and how they're managing, and where are they in the outbreak.
Thank you very much. Ed, there is a question coming on mental health services, and what is WHO plan for mental health of people during this pandemic?
Yeah, I mean, this has been a big question, and I think there's several layers to it. One is obviously access to mental health services and planned mental health services. The second is the impact that the virus has had on all of us in terms of the change in our way of living and how we perceive the world and sort of what we thought we were going to do with our lives, on a given month or day. And then the third piece, which I think is related, is how that's affecting the health workforce that, which has we had a special focus on this during World Patient Safety Day just recently on health workers and health worker safety, and including mental health issues. You can see, if you looked again back to the survey that we had around on nearly 60% of countries reported that mental health services were partially or severely disrupted. So this means that people had difficulty scheduling and accessing regular counseling sessions, but also regular substance abuse sessions. And it has the knock-on effects of that, while not perhaps immediately highlighted in terms of mortality and morbidity, will becoming really very apparent. So WHO has had a big push recently around World Mental Health Day, and a big call for countries to consider ways of ensuring safe delivery of mental health services, re-emphasizing the place of mental health within other areas, which I think, anyway, it's been an opportunity, if we can call it that. In some ways, the outbreak has for rethinking the way we structure our work. And health for many, for us at WHO, sort of exists in sort of a pillar. But now we've done a ton of work with the International Labor Organization around mental health as part of occupational health programs, as part of workplace health. So I think that it's also an opportunity to reshape the way we structure and integrate some of these services that need much better integration.
Thank you very much, Ed. And we're almost running out of time. So the last question from Hanan: is there any test which can predict immunity of a person to COVID-19? Any antibody test or mutation detecting tests?
So the first question is about the serological test, the antibody testing, which is available again. And I think we're still not sure how long does the immunity last. So again, people might take things as a false sense of security. So we do know that you can detect antibodies for this virus, and some of the studies where people hear the studies in the media about 10% of the population is immune, or 20 or 15%, and we're a bit frustrated because after 8 months we're not at 60, 70. We want to be very ambitious, because then we know that we have this very broad immunity to the virus. So that does not exist yet, but the test is available. And the second part was, is there any mutation of the virus?
Any antibody test or mutation detecting test?
any mutation detecting test. Mutations are detected through the genomic sequencing. So when there's over 95, the last time I tested, I think we're over 100,000 sequences published on the virus, and there's maybe one from Southeast Asia that showed one amino acid. So again, not to get too technical, but there was one tiny mutation that did not show any impact on the transmissibility of the disease, nor is it in a domain that's critical for vaccine development. So I think that's what the audience might want to hear. So there's no scary mutations that have been detected so far. So I guess that's the good news. But antibodies do not detect mutations. So that's through the sequencing of the virus.
Thank you very much. This
You're
was
welcome.
very helpful. Before we close, what has been the biggest achievement so far, in your opinion, from the ACT accelerators, and what has been the biggest innovation, in your opinion, that we've seen in this outbreak, or actually in this response?
I think I want to echo again what Ed said at the very beginning. I think the ACT Accelerator was able to bring a lot of the partners together, and for us as WHO, as the global health leading organization, we were able to insert many of the entities that already existed for the response to the pandemic and enhance that through this collaborative effort, and also expedite. I think it's the speed. We've been working much closer together, and the communication between the agencies, the speed of how we've been doing our work, and the unified agenda really into acting together, into finding solutions for this pandemic that has really affected countries at all different economical levels and income levels. So this is not something that's peculiar to one income level. It's everybody has been affected. So I think that's a major thing, and the speed of and the number of, this is really mind-boggling. The number of vaccines that are in the pipeline, the number of diagnostic tests that are in the pipeline. People may not sense that because they're waiting for that silver bullet, that vaccine, but what exists already is huge achievements, I think. I don't know what else.
No, I would completely, if you hadn't said it, so anyway, Hanan took my answer, but I do think that on this point that it's like, the two things I would emphasize is that this partnership working between the different global actors, which, the World Bank, WHO, Gavi, Global Fund, CEPI, and all these other partners that are out there, that maybe, certainly if I were talking to some of my Facebook friends, none of them would know who any of those are except for WHO, maybe, I hope. But the fact that this global architecture is not just talking, but actually doing work together and actually on an ongoing basis. But then secondly, because I like to return to this, somehow I had a colleague who was a very senior person in an unnamed country administration say, I've suddenly realized that there are so many pieces of health systems that I need to care about as a policymaker that I never cared about. Supply chain, whether there's enough glass in the world, whether we have enough syringes, that all of us just thought functioned out there. And I think there's a lot of that thinking that none of us have pushed ourselves to understand, like, what is the quote-unquote health systems, a broad term, but what's sort of the plumbing underneath all of this big structure that needs to keep running and functioning that we've never worried enough about before. But because every country's facing this right now, every partner's focused on it, we are worrying about it now. So I think for me, that's the big innovation.
Thank you, Bob. This was a really great discussion. And Ed, I'm sorry, I can't neglect this question because does COVID have an impact on the attention of neglected tropical diseases?
Yeah, very good question. And definitely we saw a big impact on service, both delivery and also some of the, when the outbreak first started, many countries, whether they had high caseloads or medium caseloads or even low caseloads, many countries shut themselves down. So that meant not only could you not go to the health service unless you were very ill, and many people were afraid to, but also it meant that community outreach services were very much shut down. And so WHO and UNICEF with IFRC came out with a guidance on how to safely head out into the community. And a lot of the neglected tropical diseases work is based on community outreach work in low and middle income countries. And so that thankfully has restarted, but it'll be one really to watch very carefully as we go forward.
Thank you so much. Thank you for your time. I thank all our viewers for their questions and for watching us from Singapore, Brazil, Belgium, Philippines, Nigeria, Russia, Myanmar, Norway, Qatar, Thailand, Iraq, Pakistan, Bangladesh, India, Kenya, Morocco, Malta, Scotland, Colombia, Bhutan, Ireland, Italy, South Africa, Namibia, Serbia, Sweden, Uzbekistan, Botswana. The list is very long. Once again, thank you very much. Stay safe. Just to clarify as well, we are not wearing masks at the moment because we are sitting more than a meter apart from each other, and the room we are sitting is having a good ventilation and we can still open the windows. Until next Wednesday, please follow us on our social media channels or follow our website for more updates and information. Thank you.